Were there specific gaps in care or justice that you saw that made you realize that you have to build share equity?
Absolutely. I actually had the opportunity to meet Dr. Gomperts like pretty early on in this journey. And I was in Paris at the time, and I flew to Amsterdam and I met her in a cafe, and she started telling me about how she provides care and how she works with the World Health Organization protocols, and how she really thinks about like accessible care that is scalable. And then right after that, we wound up in the pandemic, and I've been working on this project for a while, inspired by the work that she'd described to me. She actually gave me a little bit of a mission. She said the United States still really lacks a safe abortion hotline, and she gave me a task, and I was working on it religiously. And we launched basically the day we went into lockdown in the pandemic. And then in June, at this time, I was still working at my day job. I was working on voting technology. I was still working on this project for kind of for quote unquote for Rebecca, for the nonprofit I was working on, but inspired by her. And then I was also still a volunteer at Access Reproductive Justice, which is California's abortion fund. We would give money for folks who called for care. I spent a lot of time once a week on the phone talking to callers. So I learned a lot about the care gaps, even in California, where there's supposed to be really good access to abortion care. And in 2020, in June, mifepristone, which is the second drug in the medication abortion protocols, was taken off of the REMS, which is the risk evaluation and mitigation strategy, like protocol that the Department of Health and Human Services like maintains. And the reason for that is that the drug had been put on there like erroneously for political reasons. The other drugs that are part of the like risk mitigation strategy are like cancer drugs, like drugs that people can't administer themselves. But mifepristone is just a pill. It's safer than like aspirin. So on there really for politics. And then a judge in the federal circuit ruled that during the pandemic, you have to have telehealth. There's just no conscionable way we can make people drive to an abortion clinic, wait in the abortion clinic, go through a 2-3 day waiting period, depending on where you are, if you can just get the pills mailed to you at home. And so that decision really launched telehealth in the United States in terms of abortion access. One day it existed and the next day it didn't. There have been some folks working towards that vision for a long time, the folks at Plan C, the founder of Hey Jane, but largely the industry didn't exist one day and then the next day it did. And as an abortion funder at the time, as a volunteer, I really started to wonder what digital strategies could be used to deliver dollars for care efficiently, because the entire nonprofit infrastructure that we use to pay for abortion care was created in the 70s. It's a beautiful, powerful system, but it's still very brick and mortar, it's very manual, and the frontline staff that deliver the care don't always have access to the best tools. So I really wanted to understand what I could do with my technology skills to give them access to the best tools so that they could ensure that telehealth was really both scalable and affordable. And that's how I got into the next phase of the work.
Wow, that's wonderful. So before you started this, you were in tech. How has your life changed from before share equity to after?
My life is completely different, I would say. Being an engineer, working for like a larger concern, you're really just worrying about taking on the tasks that people assign to you, right? So you get a ticket or a bug, you work, deliver the feature. You don't have a say in the business typically, unless it's a small company, or unless you're a founder, unless you're a technical founder, which I eventually got to be. And when you're an engineer, you don't always get to be in an industry that you're passionate about. So I feel really lucky because I now get to do all of those things. I'm passionate about the industry that I'm in and the work that we do. I care deeply about ensuring that women and trans folks get access to abortion in an administration that's really trying to prevent them from doing that. But just in a broader political context, that's really generally that really centers misogyny and doesn't allow people to have autonomy over their bodies. And I get to drive the strategy of the business, which is really different than my previous career. I get to do the budget for my business. I get to be part of a lot of different business strategy, like considerations that are exciting and growth oriented. And that's a very different experience than just coding for your day job. I also got to be a technical founder. So I designed the two programs that Share Equity was built on top of. And that was also really exciting to get to design the program content and the tooling and select the technology and work with the engineers who built it and work with the product owner to make sure that we're building what clients and what abortion seekers really want. And of course, it's an enormous privilege to design technology for abortion seekers.
When you say you were able to build what people really want, making it this partnership or collaboration where you're building with people, how did you ensure that what you're building is really what people need?
We could always do better with user experience research. So I won't claim that we have all of the data. And I think that's a really interesting thing about this industry as well, which is that at least at the time I was entering, there were opportunities for folks at the grassroots level to come in because 2020 was such an enormous seismic year of change for this industry. Things were so different overnight that it was necessary to really rethink how we conceptualized access. So I got to be really scrappy and go with the learnings, go with my gut to some extent, and go with the learnings that I had learned as a volunteer at Access Reproductive Justice. Since then, we learned a lot about the landscape from partner relationships, from serving individual clients, and from their direct feedback, from direct user feedback in those contexts. And now that we are scaling and we have large national partners, really at this point, getting to take a step back and think more comprehensively about user research and how to form strategic partnerships to elevate that research and make sure that we're focused on their correct data points and really think about the multiple use cases of abortion seekers because there are so many, there's not one type of abortion seeker. There's so many different ways for someone to be an abortion seeker. So getting to think about that at altitude is what we're doing now. But I think that the most gratifying thing was early on, I got to talk to a lot of really amazing people in the movement and just get really direct feedback because I would go up to folks and say, hey, we're building this thing, we built this thing. Do you want to see a demo? Do you want to try it? And we got a variety of feedback, but some folks gave us really profound feedback, even to the point of like emotional responses, saying things like, I don't even think you know what you've built. This is the thing. This is the next, this is the way that we'll be thinking about abortion access in the future. Frontline staff and go through a lot. They're just incredibly tough, incredibly passionate people who not only provide medicine, but also run really, really scrappy businesses that weather incredible, legal contexts and financial contexts. And so to hear from those folks that something that we built is useful or game changing is really gratifying to me. So that's been really great.
In terms of equity itself, for you, what does it mean, not just in theory, but in practice and in the context of reproductive health?
That's a good question. Equity means, in short, it means meeting people where they're at. So it's not changing the law so that theoretically anyone can get it. And it's not giving everyone the same thing because everyone has different conditions. But equity is saying if something is a human right, we have to meet people at wherever they're at in order to be able to access that human right. So if we think that abortion is a human right, or the right to raise your kids in a safe environment is a human right, or the right to have a safe birth is a right, we have to understand the social determinants that are associated with the context of the folks seeking that care. And then we have to systematically go through landscape change exercises and healthcare vertical like change management in order to affect interventions that can better assure those outcomes or that can create that impact. So for example, in abortion access, there's a couple of key decision points in a patient journey: patient information, scheduling, and funding. If someone doesn't know about an abortion, they can't get one. If someone can't get to the appointment because they don't have time, they can't get an abortion. And if they don't have the money to pay for the abortion, they can't get the abortion. So these are three key touch points that we're really conscious of when we think about our theory of change and how we structure our workflow process and intervention. So we seek to assure that the patient has all three of these critical pieces of information at the appropriate time. We actually want patients to have as many of these resources up front, even before they schedule an appointment, as possible. After they schedule an appointment, it's too late because they may already, for example, there could be an appointment that's tomorrow, but it's more expensive and it's closer, let's even say that. But there could be an appointment that's further away that is cheaper, that is in 2 weeks, but the person's gestational age is still in bounds. And depending on someone's life circumstances, the cheaper one may be the better option, even if it's further away and they would be further along in gestational duration. So we can't, but when users go through a like healthcare seeking exercise, think of how much attention and time you put into finding your dentist or into finding your like ophthalmologist. Probably some, but like not a huge amount, right? So you're probably just looking for someone who's close to you in network. But with abortion providers, because there's so few and the demand is so great and there's so much complexity to the landscape and people are under so much stress at the point of needing to seek care, that process can be even more fraught, like even more erratic. And being able to compare all of those metrics is even more important because time is of the essence as well. So we want to give the patient all that data up front, actually, even before they make the appointment. They should know where the appointment is, how much it costs, what it takes to get there, how long it'll take them to get there, if they can go when they have time off of work, when they can get a babysitter, if it's the best option, if it's procedural or medication, if they want to self-manage. All of these options should be given as close to upfront as possible. And then we should be effectively holding the patient's hand throughout the rest of the journey because we know that there are so many different touch points. The average abortion seeker now goes through up to 14 individual touch points with a variety of care services. That could be abortion providers, abortion funders, folks handling the travel and logistics. 14 times is a lot of time to interact with the healthcare system on the way to an appointment. Like, again, think about it. If before you went to the dentist, you had to talk on the phone 14 times to someone, that's pretty exhausting. And especially if you're stressed, right? You have a really bad cavity. But that's what most people have to go through these days, especially with, again, the reduction in the footprints of the abortion providers in the landscape because clinics have had to close. We really want to accompany people through that process and reduce the number of touch points to simplify and streamline it as much as possible. So that's our theory of change in terms of the interventions that we seek to provide. And we believe that this is an equity-based solution because we know that these are the points where people fall off. We know they fall off if they don't have the information. We know they fall off if they don't have the money. We know they fall off if they can't get there. So we really want to guard around these touch points to ensure that the through line is consistent and it's the same for everybody.
That's really cool. It's awesome to hear how you break down the process into distinct steps. With share equity, how do you see it addressing these points or like the changes you've seen with the support you offer?
So our tool sits within healthcare verticals, and we work with abortion providers and frontline staff to automate the process of funding an abortion and seeking an abortion as much as possible. So we offer a fully digital case and grant management system that any organization who either has patients or funds can leverage and use. And we support with the change management internally of ensuring the appropriate adoption of that system. We center patients in terms of that particular platform because we attempt to put the control in the patient's hand. We have a form that a patient can fill out. They provide their medical appointment details, and then we can match them with different grants without them having to make a call or without a case manager having to place a call or do math in their head essentially to allocate and administrate the funds. And we also are working on a digital strategy to ensure that the appropriate patients are placed in the appropriate context. We have lots of different partnerships across the landscape within healthcare verticals, meaning healthcare providers, or with membership and partnership organizations that work with a variety of different verticals. And we seek to integrate and collect as many of those learnings and the value that those organizations provide as possible so that patients can have all of that information again upfront. If it's about available clinics, referrals, funding, options counseling, we really seek to aggregate all of that. So if you think of the journey like a sandwich, we think of ourselves as the bread. We like to think of ourselves as holding the process together.
That's awesome. Can you share a story of a provider that you've worked with and like the impact that they've seen from working with you?
Absolutely. So what impact have providers seen from working with us? We've had a variety of really positive feedback. So patient navigators do they do the Lord's work? They answer the phone whenever somebody calls. They triage individual patients and make sure that they can meet their access needs. But some patients don't need a ton of individual like feedback. They basically just need a set amount of dollars against their abortion appointment. And that process is pretty standard. So we sought to automate that again by having a like asynchronous like patient intake feature. And case managers reported that in 40% of cases, patients were able to get through fully automated. And that improved the lives of case managers at that particular facility. And we were really excited about that.
Can you share, in your words, reproductive justice? What does that actually look like? What does that mean to you?
Absolutely. Reproductive justice is a framework that was created by Black women in, I believe it was the within the last 30 years. It's a recent framework, but it essentially takes human rights and applies it to reproductive health, but then looks at it more broadly and from a racial equity lens. Broadly speaking, reproductive justice is the right to have children, the right not to have children, and the right to have children in a safe and healthy environment. It's actually not inherently about abortion. It's a broader, the framework has greater altitude. The right not to have a child, that's clear, that's the right to access an abortion. Or it could potentially be the right to relinquish a child in a way that is like safe and affirming, which is a different story. And relinquishment doesn't happen very often, but when it does, we need systems that work for people. Then the right to have a child is like the right to safe maternal health care. Black women are like twice as likely to die than their white counterparts of the same socioeconomic category in the United States. And birth, essentially complications from birth. There's indications that if a Black woman, let's say, gives birth outside the United States and then comes into the United States and gives birth, that second birth is more likely to have complexity. So there's something about being in the United States and not only the medical system, but the broader tenor of unwellness that accompanies the embodied experience of racism that is like particular to this country. Like Serena Williams almost died giving birth, right? So it doesn't matter how much money a person has, it matters how well the system is committed to taking care of someone's body during the process of childbirth. Maternal health is a really important consideration as well. And then there's the right to parent in a safe and healthy environment. So that could be anything from food security to gun control to considerations around environmental racism. Reproductive justice is a really holistic framework. It looks at health and wellness and the right to parent and the definition and structure of a family, as it centers that as a unit or units of interest. But then it pontificates on what a just and equitable society needs to look like in order to create that. So I like it. I like that it's inherently an anti-misogynistic framework and it centers on people in reproductive capacity.
Thank you for sharing that. It's very, very insightful. So, can you share with your work and your mission, what are some of the systems that you are actively trying to disrupt or change?
It's interesting. I try not to think of myself as disruptive, but since you asked, I think systems, there's, for lack of a better way of framing it, I think there's physical systems, and then there are these larger structures that we live in. So physical systems that we are working to quote unquote disrupt and change is basically the nature of the patient journey today. We really want to center the patient and ensure that they have a gold standard of personalized care. And that has just been made to be so impossible in the United States today. Aside from abortion acts, we don't have a functional public health care system. So really no one, so many people aren't getting even a bare minimum of care, let alone the care that's actually best for them as a human, that fits that meets them where they're at, that's equitable. And when people do manage to get that, it's often an enormous struggle. It's like an uphill battle. So we want to eliminate that entire paradigm and just have a functional, probably something that looks like more like a universal healthcare system in the United States that in this case centers on abortion access, but with dreams of being something bigger. To that end, we want to disrupt systems of poverty and economic suppression. It's really only in a country where we shame people for being poor that it's reasonable to deny healthcare to millions of people who need it and to justify that as being some kind of social good. Like the American discourse around health equity and like socialism is so ridiculous. It's not even real. There are so many places in the world where there just is an understanding that it's good to have a healthy populace and that people need to have health care. And the only way to ensure that they do is to give it to them and to put the money and the infrastructure behind it. So we seek that level of disruption as well, like this systems that really serve to reinforce oppression and socioeconomic oppression. There's also racial oppression and misogyny. I think that reproductive health care is such an interesting locus of focus because it really collects all of these different influences. Because women's health, for example, or health for people of reproductive capacity, like the broader category of women's health is like looking at people assigned female at birth and the variety of ways that healthcare indications show up for them. So it's not only reproductive health, but also, for example, people assigned female at birth are more likely to have Alzheimer's. But so much scientific study doesn't actually center on the bodies of people of reproductive capacity. A lot of the subjects of studies are men. So we actually know a lot less about how certain like diseases, for example, work in the bodies of people of reproductive capacity. There's just so much ignorance. For example, it was only until recently folks started being able to measure the pain level of menstrual cramps and then realized that it was in some cases like similar to like a really serious wound, like a really serious injury, like the pain levels. But women have been going to work for decades, like with serious menstrual cramps, right? People of reproductive capacity have been going to work forever with like menstruating, and no one has ever noticed. So there's something about making the invisible visible within the bodies of people of reproductive capacity across the board that's interesting to me. And that has to do with reversing misogyny at the health equity and the physical level. And then, of course, racism is an important issue to me. This country just doesn't really have a history of caring about and understanding and valuing Black and brown bodies. Black folks were brought here as chattel slaves and we were property. And I think that logic still really stands in a lot of the ways that we see systems like the prison industrial complex and the healthcare system really churn out, really focus on profit over humanity. We just assume that bad things happen to Black folks, to brown folks, and there's not as many questions asked as there should be. So I think so reproductive health for me, long story short, sits at the intersection of all of these different influences. And so we seek to disrupt all of them by ensuring in a relentless and joyful and systematic way that folks have access to the healthcare they need and deserve.
It's so insightful to hear many of the things you shared, especially what you shared about the menstrual cramps, how a lot of the studies that are done aren't actually done on bodies that can actually give birth. I'm curious if there's something else like that that through your work you've learned, like a surprising fact or figure that you want to share.
I don't know if I have one off the top of my head. I'm sure I have one somewhere, but not off the top of my head. I'm sorry.
No, it's okay. That one itself was surprising and like very informative. So I was curious if there's something that you're like, oh my God, I can't believe that this is the case.
Data changes a lot. In 2017, the average abortion appointment was $550. Today, it's between 800 and 3,000. Maybe it's not incredible unless you work in the space, but it's a significant shift. And one thing that's interesting about the landscape is that it can be hard to collect data on. People are always constantly trying to collect data, but it can be really hard to get a big national picture in real time. And that is part of what, as a digital health equity tool, we want to seek to support the remediation of. We should know in real time where it's not affordable to get an abortion, where dollars need to be moved, where resources need to be moved. But because we're so cut off from each other, the way that the abortion space is configured. Sorry, one of my students is calling me. It can be really challenging to get the information in real time.
I know you mentioned before that one of the things is like building a collective or a coalition. Can you speak a little bit more about that as a way to make significant change and movement in the industry?
Working in coalition is something that people in the space really value. It's pretty common. I think there's a lot of willingness to work together for the greater purposes of the movement. I think where those efforts are the most effective, there's just really an ability to have a tightly aligned goals, like mission, vision, values, and a willingness to work through conflict and uncertainty to collaborate across concerns. So I've definitely seen a number of successful coalitions, and they definitely make us stronger. One organization is often small. It may be small but mighty, but it can be small, and we're greater when we work together to increase our collective impact. So I've seen a lot of really successful partnerships and really value the relationships that I have in the space, and folks who are just so willing to welcome folks with open arms and work together in the greater spirit of the movement.
That's wonderful. Okay, I have a couple more questions. One is, what keeps you up at night?
A lot of things keep me up at night. I think that I tend to be like a catastrophic thinker. It's what makes me paranoid enough to want to build systems, change tools, sometimes years before they're necessary. But it's also a little crazy making, especially in a context where now so much is actively going wrong and so much of what we could dread and so many things we never even thought to dread are happening. So that's really overwhelming. So there was a few moments at the beginning of this year where I wasn't really sleeping because I was just staying up and consuming news. And then I had to go on a little bit of a news fast, and now I am much more careful about what news I consume, and that's been really helpful. I try to focus on what I can control. All right, there's certain things I can control or I can influence, and there's many things I can't. Right? So I try to stay within the locus of control of the organization that I run in terms of what I really focus on. And there's some laws and some things that do fall there that need our attention, and there's other things that I shouldn't worry about because they won't do any good.
That's wise advice for anyone who is entering this space. On the flip side of that, what inspires you? What gets you up in the morning, excited to do this work?
It's usually my clients. I just really appreciate abortion providers. I think they're super funny, they're super tough, they're super smart, they know their business. So anytime I have a client call, I get really excited about it. I like coalition spaces. There's a lot of spaces that I participate in. I like working with the team specifically around ideation, strategy planning. So that gets me up. Of course, I get riled up when there's something I need to focus on that's happening. Yeah, the work is enduring. I appreciate being able to be a part of it.
And for someone who is just entering this work or who wants to do this but doesn't know where to start, what advice would you give them?
I would say just start doing it. That's absolutely what I did. I was in my proverbial garage, which was my bedroom, and I just started asking a lot of questions. And then I started contacting people, and I found that people were receptive to being supportive. So I don't know if that's unique to this space or if that's an artifact to be found multiple places, but I found that I made friends, and then I wanted to build things to help those friends that I made. And it was a virtuous cycle. So I would say just start.
Okay, what kind of world are you working to help birth?
It's a good question. I think it's a good question without a complete answer, but I think that's what makes it beautiful. So I follow Adrienne Marie Brown. She talks a lot about the role of science fiction in envisioning Black liberation. What I like about her work is that it's really expansive in its scope, and it contemplates that everything is connected and that we need to fundamentally rethink all of our human and more than human relationships in order to foster a world that we want to see. I think a lot about the intersection of religious and spiritual movements that aim to advance the unity and the spirit of mankind with the evolution of movements for human justice and civil rights. And I think we are at the beginning of something interesting. Folks like Gandhi and Martin Luther King followed Gandhi to some extent and was inspired by his message of ahimsa and satyagraha. And that spiritual context has ultimately created the environment for a free India, which is amazing. And then Martin Luther King, and of course, many other civil rights activists also learned from that tradition and pulled that energy into Black liberation theology. And that was really the underlying energetic catalyst, I think, for what ultimately was the civil rights movement, which of course ended in legislative changes. So I think that for the next generation, we're actually at the beginning of something new because on the political left, a lot of the institutions like churches have really lost a lot of their, except for the Pope. The Catholic Church is having a resurgence. They're at the forefront of the revolution. Who knew? But a lot of the religious institutions have lost their grip on as an organizing factor within the political left in the United States, but not so on the right. They're incredibly powerful and causing a lot of trouble. Of course, from my perspective, right? They're a major organizing principle. But I think that if what we want is to break down and change institutions so that they're fundamentally more just, and that means that there needs to be a really like radical shift, ultimately, maybe slow, but like ultimately a really fundamental shift in how we conceptualize just institutions, then that's actually a spiritual question. It starts around how do we create an organizing principle that is liberatory, is capable of organizing, is visionary, but is not rooted in the same systems of oppression, patriarchy, money for the wrong purposes, et cetera, segregated yada that we've seen for so many years. So I think we're at the beginning of a really interesting question. And I want to be part of that world for sure. I want to be part of that world. And I think where I envision myself in it is as a spiritual person. And it's also just trying to lay a rational framework, right? Like my job is to say, we just need healthcare. There's some basic things, right? Like they have abortion access in France, they have abortion access in a lot of places, right? We just need these basic things in place. I'm thinking about America specifically, but of course it's a global question. But it's a bit, if we can shore up some basics, like some basic understandings of what human rights are, and especially in the places where there are these deficits, where there shouldn't be deficits, like the United States, then I think we can have, I think a broader movement will come from there.
Thank you for sharing that. It's very beautiful to hear how you see the world and your role, your unique voice and message and mission within it. So, one last final question is if this were your last interview ever, what is one message that you'd like to leave behind and share?
I think I hope that the work speaks for itself and that it's good. I would hope that I don't really have a message except we need healthcare. Abortion is healthcare. I guess that's a message. Abortion is healthcare. People need it. Give people abortions when they ask for them. But I hope the work speaks for itself. I don't think I have anything profound to say. I think it's just normal and therefore profound to take care of each other. And I hope that's what we've built.
Thank you so much. This was really lovely. It's really amazing to hear you share all of this. Like you said, it's so normal, it's so basic, and we just need to remember.
So basic. I'm basic.
Thank
Thank you.
you. Bye.